now, the Merit COVID-19 webinar series. My name is Danish Bhatti. I'm the co-chair for APPNA MERIT, and I will be moderating the session today. Hey, Wakabai, if you don't mind muting yourself just for this time, because the echo is still coming in to us. Very good. So I just wanted to quickly go through a couple of house rules and how the session is going to go by. We will start with a very quick introduction by our president of APPNA, Professor Naheed Usmani, about the series and a note of welcome to everyone. And then we will start with the speaker introducing himself and giving his presentation on the topic. And then afterwards, we'll go through the introductions and comments from our panelists one by one to add on to what the speaker has presented before we open for the discussion. So it will be about 30 minutes or so into the presentation before we start with the panelists, and then another 15 to 20 minutes for their comments before we start with the Q&A and any questions. Ideally, you can submit the questions in Q&A box. That would be perfect. However, if you are not having access to that, and if you can see the chat box, then you can share your comments in the chat. There are ways to share different links to websites. So if you're referring to something or a resource for a website, you can share in the chat box. What we typically do is that we save those links and put it on a resource file for the webinars, and we share out that file often. And we've been collecting all these resources since we've been doing these webinars. And sharing something more like a document, you can sometimes do that as an attachment in the chat that goes to everyone. And if not, you can always email it to appnamerit@gmail.com, and then we'll be happy to share it on our WhatsApp groups and also add it to our website and to resource folder that we have for these Merit webinar resources. So welcome everyone. So I think we are exactly 5 minutes after the starting point, and that will be my cue to invite Professor Naheed Usmani, the president of APPNA 2020, to make her welcome remarks. Professor Usmani. Professor Naheed, please unmute yourself. Yeah, please go ahead.
Thank you so much, Dr. Bhatti. Thank you everyone for joining in this very important series of webinars. As you know, this COVID-19 pandemic is unprecedented. It has affected a lot of healthcare workers internationally. I keep on reading about the number of physicians who have succumbed or are fighting COVID-19 infection in Pakistan, and it's extremely concerning and upsetting. Initially, we thought about the lack of PPEs contributing to it, but now it seems that every member of a family is getting infected. So a lot of stress all the way around for those physicians who are working on the front lines, and then the fear of contracting the disease if they haven't contracted, then losing other friends and colleagues to this disease. So it is just huge what the Pakistani physicians and healthcare workers are going through. And I'm so grateful to the Merit Psychiatry, Dr. Bukhari, who has started these series of webinars to sort of offer psychosocial support to the clinicians in Pakistan. So welcome everyone. I certainly can use it. Any physician who is treating patients with COVID and is working frontline needs to be aware of internal resources and external support mechanisms that they have to access and give to each other. Thank you very much. Now I welcome Dr. Shehzad Niazi, who can introduce himself and start his presentation. Thank you.
Thank you, Dr. Usmani. Please go ahead, Dr. Shehzad.
Assalamu alaikum and good evening, everyone in Pakistan, and almost good morning and good afternoon in America and other places. Dr. Usmani said it very nicely, and the challenge is very real. And we all are dealing with these issues individually and at the organizational level, where some of us are involved in some of these institution-based activities. And I will share with you some of the tools that we have shared internally. And what I do at Mayo Clinic is that I do a few things. I'm a consultation liaison psychiatrist, and I work mostly with our transplant center and cancer center here. And I also do outcomes research, where I study healthcare delivery and development of services and large data set analytics and use of artificial intelligence in developing predictive models. I'm part of the Physician Wellbeing Council, and I am one of the members of the resource panel. So when any consultant or one of our leaders are struggling with any issues related to distress or burnout and what have you, I help or try to help those particular individuals. So with that, what I'm going to do is that I'm going to talk about today some of the resources, as I said, that we have shared internally about how we can individually manage or try to manage the stress more effectively, and also give you an example of an institutional portfolio that has been developed at Mayo. All right. Do not have any financial conflicts of interest to disclose. If you look at this painting, I've been fascinated by this particular painting for a few reasons. It is by Bruegel, one of the Danish genre painters. If you look at this pastoral scene, you can see the farmer, you can see the shepherd in the foreground, then you see the ocean and the ships in the middle ground, and in the background, you see this nice mountain vista. But then you look at the title of the painting, and it is Landscape with the Fall of Icarus. And you say, Icarus. And you wonder about as to where is the Icarus? And you realize that here is this poor fella just right here, basically recently fallen from the sky and is about to drown. And all you can see is the legs. The painting is considered to be a parable on human suffering. And the idea is that all individuals are suffering, unfortunately, and the world around us goes on, sometimes without caring much about it. As a result, it is critically important for all of us to take better care of ourselves. Now, the physicians, in particular, healthcare workers, are at a higher risk of having problems when dealing with pandemics like COVID-19, because we are on the forefront. And some of us have unfortunately paid the ultimate price and have died as a result of contracting this virus. Healthcare workers have been hailed as heroes in recent times. But they are working in very difficult situations. A risk for violence against the institution where we are working at, or towards our own self, remains very high. Lack of resources, and not just in America, but in many places, even in America, has been placing the healthcare workers at a higher risk of exposure and bodily injury and harm due to various reasons. So it becomes difficult to practice in this type of environment. If you look at the specialty that is supposed to be poised to take better care of the individuals, you realize that even that specialty in itself has been struggling historically, and that has continued. I think one of the better articles, or perhaps the best one that I have read in the recent times about the situation, is written by one of our panelists, Dr. Aisha Mia. And I couldn't agree more with most of it. And especially the statement that while a small percentage of us will catch the virus, everyone will be psychologically impacted by it. And as I mentioned, that the specialty that potentially can help has been underfunded, has not been taken care of, and the wellness of the population is at risk. And we may end up paying a huge price for this because of lack of focus on this over the years. That is why it's important that we take better care of ourselves for very selfish reasons and for very altruistic reasons. Selfish reasons because it's good for us to take better care of ourselves, and altruistic reasons because you don't want to be caring for other people when you yourself are falling apart. That's why the physicians who are burnt out or depressed, they're not very good care providers either. Why is it that this whole process unfolds the way it does? The reason is that the encounter with the patient is emotionally taxing, especially in environments where the burden is very high, like for example, in Pakistan, or in private practices in America, where the volumes are extremely high. It's an RVU-based practice, more patients you see, more revenue in that type of model. And to deal with that emotionally taxing encounter, people tend to create this buffer between ourselves and the patients that we are caring for. And in extreme form, once there is emotional depletion that takes place, it gets to a point where we start to depersonalize these individuals and we don't connect very well with our patients. And we recognize that the performance that we have is subpar and it is not consistent with the internal standards that we have for ourselves. Eventually, it can lead to feeling fairly less efficacious than we are and feeling less accomplished and eventually losing the sense of purpose in what we do. Gets to a point where it can lead to mental health issues, depression, suicidal ideations, and completed suicides. If you look at the risk rates for male physicians, it's 40% higher than the general population of completed suicide, and among female physicians, it's up to 400% higher compared to general population, partly because the completion rates are consistent with the male physicians, because when they do it, unfortunately, they know how to do it right. So what can we do? Well, there are things that individually we can do, and then there are system level interventions and barriers as well. And I say this in two ways. One is that system needs to facilitate, but more often than not, system usually is a barrier in our individual effort to make things better. And a bad system will beat a good individual regardless of its intent almost all of the time. So the individuals manage their stress based on their genetic predisposition, their coping styles that they have developed over the years, their temperament that they have, the learned behaviors that we all develop. But obviously, it's only in the present that we do something about it. So we'll talk about as to 9 things that all of us can do or continue doing to manage the stress more effectively with the aspirational goal of living a more mindfulness-based life and become more resilient individuals. We will share the document. I'll share a compressed version of this document with the participants, and you can read about that. So briefly, I'll talk about 9 things that we can do, and I'm sure that our esteemed group of panelists will have a lot more to add to these things as well. I think it all begins with absolutely making sure that you're trying to find reliable sources of information about the COVID-19 itself, because there's a lot of disinformation about it. And the traditional sources, the legacy institutes, still are reasonably decent. The WHO, CDC, even though unfortunately it's more politicized now than it has ever been before. European CDC is probably a bit better. Any health agencies, local organizations, even your institute may be a good source of COVID-19 related information. And once you have identified it, try to rely more on those sources and try to consume less of the 24/7 sensational news media that, unfortunately, due to the system design, not a bug in the system, has to sensationalize things and focus a lot more on the worst case scenarios. And these types of concerns and fears become these seeds that grow into these untamed shrubs in your mind, and is enough to make you neurotic just in itself. So identify good sources and then limit your exposure to news media. Taking care of yourself is not only important for you, but it is important for people who are around you as well, because it more than likely leads to a situation where you have poor frustration tolerance, make you more irritable and grouchy and frustrated. And that is fairly contagious. It affects people around you as well, your loved ones, your family members, your trainees, your colleagues and coworkers. And it can get to a point where you can create a pretty toxic and hostile work environment if you're not taking good care of yourself. I think it starts with the very basics of absolutely making sure that you're getting your batteries recharged, that you're making sure that you're sleeping well, because the excessive worrying or ruminative anxiety can lead to 4 types of sleep problems: difficulty falling asleep, difficulty staying asleep, having difficulty going back to sleep when you wake up, and waking up in the morning feeling that your mind was working all night. If your sleep isn't too good, you can do a few things. So for example, critically important to have a consistent sleep schedule. I'm amazed in Pakistan every time I'm there as to how little people sleep. It's a huge problem, I think. I think there's a bit of a crisis. Make sure that you have a consistent time to wake up. And when you do, get out of the bed and stay out of the bed, and don't take any naps or doze off on a couch. Be physically active, engage in regular physical activities on a fairly consistent basis. Make sure that the sleep environment is such that it is comfortable, that your bed is comfortable, that the sleeping environment is dark and quiet and temperature is maintained properly. Couple of hours before bedtime, start winding down. Not a good time to start watching news channels and start reading news and all that. Instead, listen to music, read a book, do some relaxation techniques, take a body temperature raising bath or shower, and don't go to bed unless you have started to feel a little sleepy. If you can't sleep after about 20 minutes or so, get out of the bed, walk around a little bit, try to relax, read something, and then go back to bed when you're sleepy. Recognize that worry and concern are different things. Not everything is pathological. Appropriate concern is very important. And in fact, I would worry more about individuals who are not concerned about the situation. Have a plan for emergency. So for example, God forbid if one of us or our family members get exposed and has to quarantine, what are we going to do? Who is going to take care of the chores and the responsibilities that we have? What if our elderly parents get infected by it? Who is going to take care of them? What will happen? Get an emergency plan with the family's feedback. And if it makes you feel better, write it down. Recognize that you can be worried about a lot of different things, but there are very few things that you have control over. Being very intentional about as to how you're going to focus and channel your energies to address some issues by differentiating between the modifiable and non-modifiable factors is critically important so that you're more efficient. You don't have to be Pollyannish about it and totally ignore the challenges that you have, but then you say that, yeah, I understand that those are the issues, but what is it that I can control and do in the next 15 minutes or an hour or a day or a week, and refocus yourself and reground yourself in that sense. Some of the people have more tendency to catastrophize, but we all have these automatic thoughts in our head that pop up. And it is important that we do not let these go unanswered. In other ways, it's sort of like coming up with the evidence to refute these thoughts and challenge them. If you're afraid that life will never return to normal, recognize that humanity has been through pandemics and we will reach a new normal at some point. If you're worried about getting virus, as I said, having a plan in place is important. Reminding yourself of having that plan is important. Also recognize that if we do the precautions that are recommended and for generally healthy individuals, the risk of acquiring infection is not astronomically high. Ignoring the physical symptoms of distress is problematic in many ways, but one of the things is that it's an easy target, an objective target to use to reduce your sympathetic activation. So distress-related tension headaches, minor panic attack symptoms, tightness in your chest, asthmatic attacks, panic attacks, those types of things can be used as indicators. Heart rate variability is one such feature, which is now used in some of the trackers that tell you your stress level based on that. And the idea is that if you can use tools to reduce the sympathetic supply or tone, it will improve your stress response as well. Different people use different methodologies. Some people listen to music, some exercise, some garden, some paint, some read, some do photography. Whatever it is that you do, absolutely make certain that you're doing those to minimize the physical symptoms of distress. Relaxation tools are available quite widely nowadays. There are multiple apps, there are multiple websites. I will have this document, we'll share with you. And there's a link on the Mayo Clinic website. And in that patient education, there are multiple videos and they are anywhere between 4 minutes to 31 minutes. I would suggest that anyone interested sample them and find which one works for you and then use that on a consistent basis. One of the non-negotiable things in stress management, in my opinion, after sleep is paying attention to regular physical activity and exercise. It is good for your metabolic health. It is good for your mental health and well-being. It will improve your sleep, attention, concentration, energy level, and all sorts of other things. It starts with making sure that we minimize these sedentary behavior, prolonged sitting, as I think it was Dr. Nasir was mentioning about how we are just basically sitting, doing all these virtual visits and all that. Trying to avoid prolonged sitting, prolonged lying down, taking regular breaks is important. The goal is eventually to get close to 10,000 steps a day in terms of your just the regular physical activity. And if you have not been active, this is an excellent time to start. And you can start by having a target of about 30 minutes each day. You can even break that down into 3 times 10-minute type of activity, gradually get to 7,000 and then 10,000. And after that, make sure that you're adding some strength training exercises. The Harvard Task Force recommendation for burnout prevention, for example, was at least about 30 minutes of moderate exercise 5 days a week. And you add 3 days of resistance activity, such as using strength training bands or free weights to use some strength training exercises. If you are a member of a gym or a club or some yoga studio or meditation group, a lot of them have started to offer virtual classes. Be aware of the resources available. If not, find something. It becomes especially important if, God forbid, you have to quarantine yourself and you have to be in self-isolation, so you need to have access to these types of resources. We all have been told to do social distancing, but the social distancing does not mean that it has to be social isolation. Human beings are social animals. It becomes extremely important that we do not ignore this. And if we are unable to have interaction with our family members, friends, or coworkers, using technologies such as this, as Skype or Zoom or FaceTime or whatever it is available to you, making sure that you are having some sort of a face-to-face contact. It may not be as good as in person, but still is much better than just this listening to them. People who are already struggling with health problems, people who are lonely or have mental health issues or member of marginalized groups or ethnic minorities, they are going to be at a higher risk of having these types of problems as a result of social isolation. So please avoid that. What if, despite all your best efforts, none of this works and you get to a point where you are so severely anxious, worried, or depressed that it has become a clinical concern, where it has started to compromise your personal, professional, academic type of activities? In other words, it has become a serious problem. In that case, the most important thing is to not ignore it and do something about it. If you were to develop hypertension or diabetes, surely you wouldn't just sit there and say, well, you know, I'll deal with it at some point. Similarly, if you get to this point where you're severely compromised in terms of your functioning, please do not ignore that and get some help. To do that, if you work in a larger organization, there are employee health resources available. If not, your regular doctor might be able to help you, or may be able to help you determine whether you need to see a mental health professional or not. For those individuals who have pre-existing mental health issues, it is extraordinarily important to make sure that they continue to take their medications as prescribed. If they are not, those medications not controlling symptoms appropriately, then get some additional help, get the dose adjusted. Make sure that they are paying attention to behavioral activation and self-management, which is regular physical activity, social connectedness, participation in hobbies and pleasurable activities. And for those who are of that bent, paying attention to spiritual and religious aspects of our lives is critically important in these situations. Very briefly, a word about resilience and so a related concept. These are the two books. There are numerous books. Read whichever book you want to. Main thing is, the result depend on what type of activities you actually implement. All these books basically say the same things. These two books, I think, are quite helpful. Resilience has 10 areas. We'll talk about that you can actually use. I have told Amit that I don't like the title of the book because there is no such thing as stress-free living. You can only manage it appropriately. Everything else is good. It basically is the summary of a 6-month-long course that you have to do, that the trainers need to do, and I've done that. And it's a very good book from that standpoint. So what is resilience? The idea is that there are 10 areas that if we focus on and improve upon, it can make us better and more resilient individuals, allows us to bounce back from adversity better. Be realistically optimistic about future, not naively, not ignoring the challenges, recognizing that fear is an adaptive and normal response. And the idea is not to suppress it, but manage it and adapt to it by doing the right thing consistently, by having a moral compass in place, having some belief in higher power, and having that seems to have an impact on our ability to be resilient individuals. Having social support around us so that we don't feel completely alone when we are dealing with challenge is extremely important. Recognizing that there are always going to be role models, but I always tell people that there are two groups of role models. There's one group that tells you how to do something right, and another group that teaches you what not to do. So having these both type of role models is extremely important so that you can learn from them. train yourself mentally and physically by being mentally engaged and engaging in intellectually stimulating activities and being physically active so that you stay in a good physical health, and recognizing that change is the only constant, that whether we like it or we don't, we're always going to be dealing with lots of changes in our lives. Where it helps is perhaps the most important thing about life in general, even dealing with existential issues, is to have some sense of purpose and meaning in life, something to aspire to. And if you have a why of life often enough, you can figure out how and what of this. Those of you who are in leadership positions have to recognize that people that you're leading, there are a few things that you need to be thinking about. One is obviously setting as an example and trying to do the things that you're asking other individuals to do, but also thinking at a system level, what is it that you can do that makes it easier for people to do the right things? Obviously, an institutional response is going to be predicated upon the local resources that are available and the environments that you work in and the context of the situation. I thought I will share with you as to what we are doing at Mayo. Just to give you an example, it's not all of the things, but it's some of the things that we just recently reactivated and recalibrated. We have employee assistance program open to anyone. And it's third party, it's confidential, information isn't shared. If anyone is having problems with family relationships, legal issues, financial issues, alcohol, drug issues, workplace problems, elder care, those types of issues, they have resources available, including mental health services. If you just want to talk about something because you're very frustrated and you want to vent or moan and groan or cry or just want someone to listen to you, or need some extra help and guidance, you can call this warm helpline. It's between 8 to 5 because it is staffed by providers, and the idea is that they can help you with some of the relaxation techniques, give you some pointers about how to deal with things, or just listen to you. If there are spiritual or religious type of issues, there are counseling available for that. We have integrated behavioral health services available for stress management using those types of approaches. Well-being courses are available as well. And we have humanities in medicine separate department that I work with. There's art therapy and related things that are available to people who are interested, both to patients and the employees, especially in this time we have revamped that. For those who are unable to manage this and they have pre-existing issues, psychiatry, psychology has this expedited process of getting them in for consultation and ongoing treatment. We have 1.5 hour consult, that's just one-time thing for stress management and resilience training, which is also a different name of mindfulness-based stress reduction therapy. It's just 1.5 hour consultation. For all the consultants and attendings, if they're having challenges, or leaders who are dealing with distress-related issues, burnout, or they have some challenges, we have 4-member panel that they can contact any one of us and we can confidentially talk to them. There are no medical records and we help them navigate through their difficult times. As I mentioned, this document will be available. So any of you who want to read some books on the topics, there are some helpful books that are, some of them are recent, some of them are sort of old-time classics. There are some helpful websites. And just like anything, there is an app for everything nowadays. And as you can see, there are some apps that you can look into. There are these couple of websites as Cyber Guide and Anxiety and Depression Association of America that does the reviews of these different apps. So that way, these things don't go stale. You can consult those websites to see if something else has come up. So with that, I will conclude my portion. Sorry, I'm 1 minute above my time. I thought I was going to do 20 minutes anyways. Here are some of my colleagues who have been contributing to some of those things, and I'm really looking forward to hearing from our esteemed panel members regarding what they have found helpful or what they recommend to other people. Thank you very much.
Thank you, Dr. Shehzad. That was wonderful. I think that's a great resource for anyone. And I actually learned a lot, and I'm looking forward to further discussion. So I think what we will do next is that I will call on the panelists one by one in the order they were listed on the flyer so that people can keep track. And I would request the panelists to introduce themselves and make their comments and add anything they would like to in terms of resource or information. And then before I start with the first panelist, I would want to tell the attendees that they are welcome to participate in the discussion afterwards. There are many ways to do that. One way would be that if they would like to make a comment verbally, then they can raise their hand. I see a couple of hand raised already, and I've noted them. And I will get to you guys and give you the microphone and give you the chance to make your comment. And then you can also type your questions in the Q&A box. You can type your question in the chat box if you're not able to see the Q&A box, and let me know of any other ways that you want to participate. Send a message to me directly. So with that, let me start with our first esteemed panelist, Dr. Aisha Mia. Dr. Aisha Mia is the founding Dean of Students and Associate Professor of Psychiatry at Aga Khan University. Dr. Mia, please unmute yourself and introduce and make your comments.
Wonderful. Thank you so much. Assalamu alaikum, everyone. So my name is Dr. Aisha Mia. I'm a trained adult and child adolescent psychiatrist. Really lovely being here. Thank you to Vakar for inviting me to be here. Danish, thank you for the moderation. Also, Dr. Niazi, those were some really wonderful slides. I really enjoyed the graphics. और आपका बहुत शुक्रिया कि आपने मेरा भी तस्करा किया. So thank you for that as well. You know, I've been thinking about a lot. In fact, I kind of sort of smile if people that if anyone asks me to do another webinar, another Facebook Live session on mental health and anxiety and depression, I mean, that in itself is causing, I think, a lot of stress amongst us all as well. You know, when you constantly kind of keep talking about these things, but then you kind of reflect back and think that, you know, what is changing on the ground? Is anything changing on the ground? We're going ahead. You know, there is an opportunity. I was talking to Dr. Ali Hashmi. He's going to be joining us in a little bit as well yesterday, that, you know, are we making a dent? Is this our opportunity in the area of mental health? You know, our golden time to actually begin to have this conversation, जो कि अभी तक उस तरीके से नहीं हो पाया है, जिस तरीके से, you know, it needs to happen. So, you know, a lot of time to reflect and kind of, I think, put together our resources and think systematically of how sort of we can move forward. You know, if we think about Pakistan, I think we really, and the sort of op-ed that I'd also written was about, you know, how mental health has really been the Achilles heel of Pakistan. We've really not talked about mental health at all. We are really at point zero. We have a very small number of psychiatrists for a huge 200 million population. Our governments really don't, they don't invest in health, and then they hardly invest in mental health. There is really no cohesive national or even a provincial level sort of mental health plan that talks about it. If I compare it to, let's say, NHS, and, you know, Dr. Shehzad might be able to talk more about it, but, you know, they have a whole separate mental health stream that's going on. And now, you know, they have their kings and their princesses and, you know, all of these very fancy people who kind of have been talking about and trying to take care of the stigma around mental health as well. So at least the conversation has started. Problem is huge, but the conversation has started. We really have nothing here. And I think that has, you know, put us very much behind in terms of, as we think about कि अब ये COVID आ गया और उसके बाद इतना major अब mental health issues होंगे. So where do we start? I'd like to start, you know, Dr. Niazi talked really nicely and elegantly about what an individual person can do. But let's talk about at the hospital level. So and I'll give you very quickly my experience. I came about 6-7 years ago. And my biggest thing was, okay, how do I take care of the stigma of mental health within Aga Khan University, right? Forget everybody else. Within the doctors that work at the university, within the doctors that work in the hospital systems. Because they're significant. You know, there was somebody who would have lost their family members, a child that is going to get an amputation, is going to lose a leg. Are those doctors thinking that there are going to be mental health needs? And now that COVID is upon us, are the doctors, are the frontline workers realizing that there are mental health needs of these patients, but also we may have mental health needs as we take care of this? So, you know, one of the things that AKU immediately did was to start a hotline that wasn't there before. But I was just talking to the, you know, people who were manning them for the past 3 months. And I said, what's the use? How many people are calling? And they said, hardly any. Okay. So we have a hotline, but people are not calling. Now, there are people that are coming in. There are frontline health workers that are trickling into our clinics. Basically individual trust level base. Some people that know me will come to me, some people will go to other, but in terms of putting together a system, we just yesterday, the Department of Medicine put together and marketed this whole webinar that they were going to hold about how to take care of yourself during COVID. Only 16 people attended. Okay? This is the largest department within the university. So in a culture where nobody really knows how important mental health is and whether they're able to sort of even pick up that these are issues that I'm having, I might be getting burnt out, or these are symptoms of stress that I'm showing. If that recognition is not there, and also if recognition ho bhi jaye, how okay is it for me to put some things aside and take care of myself or my family or my department and take care of the mental health needs. Really, I think that culture slowly needs to develop. And some of the things that I keep talking about, some of the institutional things that Dr. Niazi spoke about, that it has to happen at a systems level. When we tell individual frontline workers to take care of their mental health, to take care of their exercise, which is all, wonderful. I think that's what everybody needs to do. But here are people who are already stressed out, and you are calling them now, people who might have been on call every 4th day or 5th day. Now you're saying you have to come on call every 2nd day. You tell them that aapko itni PPEs milenge, isse zyada nahi milenge. You tell them that, you will be exposed, but, you have to go into this thing. And you also have to take care of your mental health and your, burnout on your own, because at the systems level, we're not going to provide much. I feel that that's not right. I feel that as much as possible, if we can advocate for a systems level change, and I know that Dr. Hashmi will talk about what KE has done, and they've done a really good job, that I think that needs to happen. Leadership needs to believe that this is important. Leadership, I was talking about, looking at some of the articles that have come out in Lancet and BMJ and stuff, and they talk about having this new position open up of somebody called a chief wellness officer that is going to sit at the vice provost or the vice presidential level, right? Something to that extent where you kind of say that we are putting in this kind of money to have this kind of a person whose work is going to be, and these are the resources that we're going to give them, whose work is going to be कि वो systems level पे integrate करे mental health, so that, and making sure that not everybody is not working, every 6 days, or are we plugging in breaks in between, or are we making sure that, people are not being overworked and they're being allowed to go home? Are we providing, insurance for their families अगर उनको COVID हो जाता है because hospital exposure की वजह से उनको हो रहा है और उनकी families को हो रहा है? So can we provide some sort of medical insurance for their families? So I think those are some of the sort of institutional level, government level, systems level things that we probably need to now start thinking about. And we have this great, wonderful bunch of people here, group of people here, getting everybody's input and putting some of those thoughts in place. So I'm going to leave it at that, and would love to hear what others have to say and then take questions. So thank you, everyone.
Thank you, Dr. Mia. We will, I'm seeing a lot of questions coming in and comments and raised hands. That's wonderful. I would definitely get up to all of you. If you raise your hand, please leave it raised so I can keep track of who was interested in making comment or speaking out. We will try to go through the comments from all the panelists and then get to all of you guys in time. So let me invite Dr. Nasser Khan, Associate Professor in Division of Developmental Disabilities at Queen's University and consultant psychiatrist and part of dual diagnosis consultation outreach team in Providence Care Mental Health Services, Kingston, Canada. Dr. Nasser.
Thank you very much. I'm very grateful to APPNA MERIT for inviting me. वो एक छोटे से शेर से शुरू करूँगा. I hope that everybody here can understand Urdu. If somebody is not, then I apologize for that. कोई हाथ भी ना मिलाएगा जो गले मिलोगे तपाक से. ये नए ज़माने का शहर है. Sorry, forgot about it. ये नए जो गले मिलोगे तपाक से, ये नए sorry, okay. ये नए ज़माने का शहर है. ये एक बशीर बदर साहब हैं, उनका शेर था जो मैं काफी देर से याद करने की कोशिश कर रहा था और मुझे फिर वक्त पे आके भूल गया. So anyway, I will come back to it. दो सिर्फ चीजें बोलना चाहूंगा टाइम कम की लिमिटेशन की वजह से. One is the professional pessimistic and darker side of pandemic, and one is optimistic, personal, and the brighter side of pandemic. If we talk about the darker side, the whole paradigm of psychiatry is about to shift. This pandemic is not going away. There'll be new classification system soon, which will include the virtual education, problems with it, the virtual interaction, the problems with it, how people are surviving. I was reading articles from cardiologists, neurologists, they are working, there are clotting problems with the pandemic and virus. So there are lacunar infarcts in the brain. So what kind of acquired brain injuries this pandemic is bringing in the minds of the people who are recovering. If there are definitely a lacunar changes, there will be definitely emotional problems as well. So what kind of new emotional problems we are about to see, we are yet to identify them. We as a psychiatrists are still fighting at the basic level of coping with anxiety, stress, depression. उसके बावजूद लाहौर में एक बड़ा मॉल खुलता है, and we see hordes of people there, unfortunately. But we have to think as a professional to go see something beyond the point, which is about to come. A new diagnostic classification soon will be here because we have been shut down for months. And I don't know for how many months we will still be shut down. But now looking at the brighter side of it and the optimistic side of it. So I was just talking to Shehzad as well that this pandemic has given us lots of good things, like the global warming, where the G8 were about to spend billions and billions of dollars. That's saved because the 2 degrees centigrade temperature has gone down. So now the global warming is not a problem because you can see the bright blue sky even in Lahore because of the less pollution. That's the positive side of it. We are spending lots of time with the family. We are not dining outside and having meals. वो junk food जो हर वक्त लाहौर की गलियों में खाया जाता था. I'm just talking about Lahore because I am from Lahore, so I will talk about that city mostly. वो बंद हो गया, कम हो गया. People are living healthy life. Now, these are the positive things. We are spending more time with the family. We are spending more saving money. वो जो wealth की एक नुमाइश थी, वो खत्म हो गई because you are staying home. Now, you cannot show people to come into your house how lavishly you are living. And being a religious aspect, doing wuzu 5 times a day and washing your hands 15 times a day was actually given long time ago. Now this message is prevalent. You have to wash your hands. Hukukul ibad, when you're standing in a line, you are getting so close to each other that you are not trying to feel that how distressful it will be for a woman or a man standing in front of you when you are practically touching them. Now you have to keep a distance. So this pandemic is actually revitalizing the basic concepts of spirituality and religion, which I believe, I can talk for hours on it, but I believe that's the good message. So this pandemic has taught us some good things. So we have to, as a professional, see the things a little bit beyond the policy implementation and education, little bit beyond that, because unfortunately nothing is going to change as far as the policymakers are concerned. I've been fighting for this for almost 30 years back in Pakistan, but I don't think so. I made a major impact on the healthcare system, despite hammering lots of people there. So that's just my viewpoint. I may be able to talk more about it if there will be a time and respond to the question. Thank you very much.
Thank you, Dr. Nasser. And I think some people helped you with your verse. It was "Ye naye mizaj ka sheher hai, yahan fasilon se mila karo." Thank you, Dr. Rabia and Dr. Asma for sharing that. So I continue to see many questions being put together. We'll try to get to them pretty fast as we can once we go through all the panelists. So keep them coming. I see some really good questions there that even I would love to hear the answers to. So let me move on and invite Dr. Ali Madi Hashmi, a tenured associate professor of psychiatry at King Edward Medical University. Dr. Hashmi, please go ahead.
Thank you, Dr. Danish Bhatti. It's an honor to be here in this webinar presided over by Dr. Naheed Usmani. Special thanks to my dear friend, Professor Bukhari, for inviting me. And we have, of course, a host of luminaries here, starting with my dear friend, Professor Nasir Saeed Khan, who is just talking. Professor Rizwan Taj is here, Ashami is here. I see a lot of people in the audience also who I should acknowledge. Just a couple of names. Professor Bilkis Tahir is the chairperson of medicine at Mayo. And it's important to mention a name because Mayo Hospital actually is the front line for COVID patients in Lahore right now. So Mayo is the main referral center for all of Lahore COVID patients since the pandemic started. We have Professor Murad Musa here, Professor Imran Jaz Haider, and my very dynamic colleague from Mayo, Dr. Nadish Imran. So special shout out to Nadish there. Let me just go through quickly. I was told by Bakar to just take a few minutes and tell the audience about what we at Mayo are doing, at King Edward are doing in terms of mental health since the pandemic started. So I'll just quickly go through that and tell you what we've been doing. The one thing that I'm most proud of is the fact that at the beginning of the pandemic in Lahore, around the second week of March, we had a lockdown starting on around the 23rd of March. Around the same time, the governor of Punjab, who's also Chancellor of King Edward Medical University, inaugurated our telemedicine center in King Edward. And a couple of days after that, I requested our Vice Chancellor to add a telepsychiatry section to that telemedicine center. So we now have a telepsychiatry section in King Edward for the first time in the history of King Edward. So I'm proud of that. Although I would like to point out, as Aisha said, that because of the difficulty with the awareness regarding telemedicine and telehealth, the volume of calls that we are getting is quite low compared to the need that's there. So we're working on trying to increase awareness about telemedicine, telepsychiatry, telehealth, and hopefully that will increase. I had a special interest in that because, of course, besides the fact that telepsychiatry and telehealth, we also have a corona desk and we have medical specialties providing telemedicine services for obvious reasons to prevent our frontline healthcare workers from getting infected with COVID. And Mayo has been hit very, very hard with COVID infection in our hospital staff. We've had a number of professors who senior medical staff who developed COVID. We've had several dozen doctors who contracted COVID in our own department of psychiatry. We had at least 5 to 6 people who got COVID. So we've been hit pretty hard with the virus in Mayo, and we are struggling through that. But we got news just a couple of days ago that there might be a slight dip in the cases, and so we're hoping that in the next few weeks Lahore will be past the worst of the pandemic. So in addition to the telepsychiatry service that we've started at King Edward, I've also been, so the Higher Education Commission of Pakistan, which is the body that accredits all and finances all universities and colleges all across Pakistan, requested our Vice Chancellor to nominate someone from King Edward for a national task force of mental health response to COVID-19. And I'm part of that task force, and our department is leading King Edward's role in that national task force of COVID, and we are formulating some policies and some ideas on what universities and colleges can do in terms of providing mental health and support services for their students, for their staff members, for their administration during COVID-19, because as Professor Nasir was saying, in fact, the brunt of the COVID infections, which hopefully will start to decline, will be followed by a huge spike in mental health issues, which is already beginning. We are already seeing a huge spike in mental health issues in our healthcare professionals, in the general public, in the families of patients who've been infected with COVID. So it's going to be more of a problem down the road in the next few months and in the coming years. And with the anemic healthcare, in the mental health system we have, we don't have enough funding for mental health. We don't have enough psychiatrists. We don't have enough healthcare workers. It's going to be a significant problem. So it's important for us to plan now in terms of how we're going to deal with that down the road. So another thing that King Edward is involved in is we are liaising with the World Health Organization Technical Working Group, which is working with the Pakistan Psychiatric Society, again to develop primary care interventions for all frontline practitioners, all doctors, all mental health practitioners. As you know, Dr. Aisha Mia mentioned that it's important that we focus on mental health intervention that can be applied to the broadest layers of the population. There is no way that we can deal with the mental health issues in terms of making diagnosis and doing one-on-one treatment, because the numbers are too great already. Even before COVID, the need for mental health services was far outweighed the availability of mental health services, as some of the colleagues have mentioned. So the World Health Organization EMRO region, and we at King Edward is part of that effort, and it's a national effort. We are trying to develop resources and trying to develop interventions that can be applied at the primary care level, like mental health gap, like psychological first aid, and WHO is helping us in terms of providing those services to do that for the large, broad mass of the population, which is really the only way that we'll be able to provide the services needed given the shortage of mental health professionals that we have. In addition to that, I was very interested, this is a personal thing of mine, Dr. Shehzad Niazi probably does not remember, but many, many years ago, along with my friend, Dr. Imran Khwaja in Dallas, Dr. Shehzad actually helped us with a research paper we had written. We had translated a scale into Urdu and then we made it available to researchers. So he talked about a department or a resource that they have in Mayo Clinic, which is humanities in medicine. And that's a special interest of mine, medical humanities. So, I've been doing work in that in terms of research and writing and developing groups and educating people about that, because the story that Dr. Niazi started out with, it's important to sort of interweave those stories. Dr. Nasir started out with the share, with the verse. And the population here in our country tends to respond well to poetry, to literature, to music, all those things. So I think that can be an important resource in terms of providing mental health support for people. And like I said, medical humanities is a personal interest of mine. And most doctors, especially in Pakistan, tend to be not very conversant with the humanities in general. So I've been working on that myself in a personal capacity. And I hope to continue doing that as part of the mental health response to COVID. And lastly, just a quick point. There was a mention here about the fact that healthcare workers are under a tremendous amount of stress, and that's true. I've already told you the numbers in terms of the healthcare workers at Mayo who've been infected with COVID. We actually have, unfortunately, a professor of pulmonology who's on a ventilator in Mayo right now, and there are dozens of stories like that. So really heartbreaking stories of healthcare professionals, including senior medics, trainers, teachers, professors, who've contracted COVID, and some of them who died from it. So we are under a lot of stress here in Lahore and all over Pakistan, because none of us knows when we might get infected, when our family might get infected. Every time I go to Mayo Hospital, I'm afraid that I might bring the infection back home, give it to my parents, give it to my children. So there's a lot of stress, a lot of anxiety on physicians. And so what we've been trying to do here at Mayo, and I've been trying to do in my personal capacity, is to do support groups both for physicians and for other mental health professionals. So, we are working on developing a support group. We're already doing that, doing support groups for psychologists and mental health professionals, because it's important to take care of the mental health of people who are providing mental health care. So it's important to take care of the mental health of psychiatrists, psychologists, people who are doing that, and also important to do that for physicians. So we are already doing a support group for physicians here. And I should remind everyone here that doing support groups is a cost-effective way of delivering mental health interventions to a large number of people at the same time, instead of doing one-on-one service. So this is just a summary of what we're doing at King Edward, what we're doing here in Lahore. We are very thankful to APPNA and to all of you for arranging this webinar and for listening to us at this time when we're going through this difficult time in COVID here in Lahore. And I hope to learn more from the panelists and then hopefully have some question answers. Thank you.
Thank you, Dr. Hashmi. I want to make a quick comment that I appreciate everyone who has introduced themselves in the chat box. The chat box is available to all panelists and attendees and participants. Please introduce yourself. And if I get time, I will try to acknowledge everyone who's introducing themselves in the chat box. Let me move on with our next panelist, Dr. Sarfraz Saeed Khan, who is the Chief Medical Officer and Vice President Medical Services and Medical Director at Meridian Health Services and Department Head of Psychiatry and Behavioral Sciences. And he is the Associate Professor of Psychiatry with Indiana University School of Medicine. Dr. Sarfraz, please go ahead. Dr. Sarfraz, please unmute yourself.
I was unmuting myself, sure.
Yeah.
So I think most of the important points have been discussed, but let me take a few which may have not been discussed so far. So we are primarily in Muncie. Muncie is an extended suburb of Indianapolis. So we were hit with two unfortunate struggles. The first struggle was we were one of the new 3 epicenters which were being there after New York. So that was Indianapolis, Chicago, and New Orleans. So there was a lot of stress among the physicians. The second issue was even a little bit worse, that it was figured out that the mortality in Wuhan was approximately 3.4%. That was one of the ones which, of course, later it was figured out it was a little bit less. But New York Times said that the worst mortality so far in the United States is in Muncie, which was 7%. And that made a lot of anxiety among the providers, among the physicians, and being the chief medical officer of an organization which deals with multiple specialties, we had very limited access because most of the people were working in smaller silos. We have offices in pretty much 50 counties. Every county has 2, 3, 4 providers. Anxiety was going there, and we didn't know what to do to start with. So we did a few things. The first thing what we did, we tried to tell them, we are trying to take care of you. So one of the first things what we did, we decided to provide them with the telephone lines, the helplines. The first helpline was a regular helpline where anybody could call and get the help. We had, of course, psychiatrists available, we have physicians available. But the two things which we did was a little bit novel. One was connecting them to those lines where anybody can call, any provider. No question will be asked. He would not tell his name, and he can discuss his struggles. Some people have different kind of struggles, which was having a problem with their spouse. They have some struggles with their very personal life, which they don't want to open because of stress. So we would listen, we would try to help them, and we would ask them to call back. They felt very comfortable that their confidentiality wasn't affected. That's the one way. The second way was slightly different. Once we realized that many providers were not willing to come and see the patients themselves because knowing the mortality, knowing the struggles, we tried to reach out to them what's wrong. And some people said, well, I have my mother who has cancer. She's 80. If I get COVID, I'm not going to die. She's going to die with me. So we tried to tell them, look, if you feel you do not want to come to work, we give you a time off, which is a paid leave. That's not your personal time off. That is the time off you can take if you think you are either exposed or you would not like to work. So that's second is we give them a confirmation that they're not going to lose their job. So they were allowed to furlough themselves for a period of time, getting everything. In addition to that, students was a big issue. Students were self-diagnosing themselves with COVID every few days. So sitting and a student just showed up saying, I think doctor, I got the COVID. Okay, there's a lot of anxiety for the doctor sitting too. So what we did, we took them to virtual care right away. That took some stress from us so that, we are not dealing with those students. We start providing them virtual services. All our services end up going to virtual services, just everything. We had only 2 services open. One was people can call on a line, they can discuss. और जब वो कहते थे कि जी मुझे लगता है मुझे COVID है. Okay, why don't you drive your car? So अपनी कार में drive करके आते थे. What we would do, we'll do the testing, and after doing the testing, we would say, why don't you go home? We'll call you. और उसके बाद हम, we'll do the further things. जो लोग महसूस करते थे providers कि वो ये नहीं समझ रहे हैं कि they are getting enough help in the time of the need. Then we tried to give them individual help. We took over their productivity standards. I think somebody mentioned the RVU, which was a very important thing. So what we did at our organization, which is one of the largest in the country, उनका RVU requirement जो थी, जो money making requirement थी, वो हम लोगों ने खत्म कर दी थी. इसके अलावा जो चंद चीजें जो हम लोग अभी तक कर रहे हैं, वो ये कर रहे हैं कि हमारे पास incentive plans हैं लोगों की financial struggle के लिए. We start giving interest-free loans, which many of you probably, it's very common in Pakistan, but United States does not have any concept of interest-free loans. So we start giving, interest-free loans. Residents were only allowed to go to those rotations jahan unke paas koi aur choice nahi thi. So this is what we did at our level. I heard pretty much everything. Fortunately, America mein wo struggles nahi hain jo Pakistan mein hai ki people don't consider psychiatry as a valid field. लेकिन यहाँ physicians में it's a main struggle, and I myself treating physicians with depression and lawyers, there's still a large stigma for a specialist physician to say, look, I'm struggling with depression. So ये कुछ चीजें हैं जो हमने की. I understand we have quite a few people, we can talk quite a bit here. But these are some of the things which helped us, and then slowly we are going back towards normal. If there's any question, I'll be willing to take.
Thank you so much, Dr. Sarfraz. Let me move on to our next panelist, Dr. Sumera Camber Bukhari. She's the Associate Professor and Head of Department of Psychiatry at Services Institute of Medical Science in Lahore, SIMS. Dr. Sumera, please go ahead.
Assalamu alaikum, everyone. I'm very thankful to the that you people have invited me to the webinar, and I would like to pay my regards to my mentor, Dr. Nasir Saeed Khan, and my colleague, Dr. Ali Mati Hatmi, who have talked about this issue. I would like to already most of the things have been discussed by Dr. Ali Mati Hatmi, Dr. Nasir Saab, and Dr. Aisha Mia. The people who are working at the front line, I'm concerned about them, about their mental health, because we have to deal with them. They are going through a lot of stress. They're consecutively having duties over there repeatedly, and initially that the problem that we faced was that the psychiatric residents were asked to perform duties in COVID ward, and the things were like this, that they were not given proper PPE initially, but now things are getting better. These were the issues initially, and the psychiatric mental health issues of the doctors should be dealt properly, and we have to raise the issues in our society to know that the people who are dealing with with patients, that they need some psychiatric help. Thank you very much. So it was a wonderful presentation by Dr. Niazi. Really nice. Thank you.
Thank you, Dr. Sumera. Let me go to our next panelist, Dr. Shahid Latif, who is a consultant psychiatrist and clinical director and chair of RC Psych Transcultural SIG. He is the executive committee member at RC Psych in Trent Division in UK. Dr. Shahid, please go ahead.
Thank you. बहुत शुक्रिया Dr. Danish और शुक्रिया वकार का invite करने का. It's a pleasure being here amongst an esteemed group of people, and it's lovely to see new faces and old faces as well. I think a lot of stuff has already been covered. What I would really like to do is just touch on a few elements in the NHS, particularly in our trust, which we've basically, I suppose, modus operandi, if you like, which we've attempted to establish. Some of them have worked, some of them are evolving on a day-to-day basis, because we are in a very dynamic situation. We are in an evolving situation where, so I think it was Dr. Nasir Saeed Khan who actually said that this is not going to go away. This is something which is with us for a while, and I think we need to be conscious of that fact. The only thing I would really add to, I suppose, or additionally would add, is that we need to remain positive. And while we are all psychiatrists, we also have to look after our own mental health, although that's really, really important, which actually takes me on to what we really need to be discussing in relation to, in addition to what's already been touched on. There's something in our trust. What we've actually done is, we are already aware, and we've sort of addressed the main public in Pakistan, in the States, in the UK, as to how we can assist and guide patients and carers, if you like. But what we sometimes fail to do is look after ourselves and look after our colleagues. So what we've actually done in our trust is that we've developed something which we call the COVID struggles. The COVID struggles are basically a set of scenarios which we have, a set of traits or characteristics or that may have an impact on us as healthcare professionals. And these may be at a conscious or unconscious level, but in order to bring them to the conscious level, the important thing is basically to talk about them. I won't go into the detail because I could go on forever just going through each and every point, but just very quickly, some of the things, I suppose, in a very simplistic and basic way as possible, is to put it in bullet points. And I'd be more than happy to, if anybody wants me to expand, I can. The first thing is, and the most simplest thing is, it's okay not to be okay. Okay, this is the first thing that we are selling, and we say to our patients and our healthcare professionals, doctors, nurses, occupational therapists, psychologists, those individuals who think that they have to soldier on. And that's another bullet point, that we feel that we have to soldier on. Dr. Ali Hashmi already highlighted the difficulties that they experience in Pakistan. But who's going to look after Dr. Ali Hashmi when he's feeling upset? Who is he going to go to? Who is he going to talk to? And we have this feeling within ourselves that we have to soldier on. And that's what we have been trained to do as doctors, as psychiatrists. And over these years, we are supposed to be the resilient ones. But hey, what happens to us when we fall short? So this is something just to be conscious of as individuals, that we have this within us, isn't this issue about soldiering on. So just be very conscious, and it's okay not to be okay. The other one is new roles. I've had to reestablish myself as a psychiatrist. I've had to go across the border of going from a psychiatrist who knows very little about physical health or forgotten a lot about physical health to reestablish new knowledge, etc., which is fine. I mean, as we are all students and we all learn new things on a day-to-day basis. But the new role actually entails that we have actually had to work either in isolation or from our offices or from our homes. And these are some of the issues which we've, when we were working, we would say we would love to do that because do we want to go to work today? No, I prefer to work from home. But hey, now we're working from home or from the confines of our offices. What it's actually done is that when it goes on a chronic basis, this can start having an impact on different individuals based on their own vulnerabilities. And this is something which is coming to the fore. And this is something, I'll be honest, something that I started feeling. I like interacting with individuals, going into the wards, talking to my colleagues. And for a while, after about 5-6 weeks, I actually started to feel it. I don't know, I got a little bit irritable, but I started to ask some of my colleagues that, what? And they said, what? Actually, we are actually, as healthcare professionals, have also gone through a very mild to moderate grief process. You know why? Because our old ways of working in comparison to our new ways of working, we haven't been able to say goodbye. So when you're not able to say goodbye, we've been suddenly thrust into a new way of working. I was talking earlier on before we started the panel to Dr. Nasser, and we was talking about this whole issue about the positives of COVID-19 and how we've suddenly had to cross all the bureaucratic and the red tape of NHS and suddenly operate in a virtual way, which has its benefits. But it's happened too suddenly. So we just need to be conscious of these things. The other thing I would like to add is something in relation to the boundaries dilemma. Those individuals who are constantly working from home or working from the confines of their office, we used to work, well, most of us, in an orderly manner in the NHS, what we've done, and I'm sure it's slightly different, but we work 9 to 5. So we wake up in the morning, shower, coffee, peete, we drive to work, get into work, and get started. That's gone. We wake up in the morning, it's straight to our desk. What's our check-in time? What's our check-out time? Where's lunch? Where's dinner? Suta break idhar hai? What's happening to all of this? Where's those colleagues? These are some of the things that we need to be conscious of. They may sound very simplistic, but you know what? These can have a major impact on healthcare professionals. So very, very important to make sure that we maintain a check-in and a check-out time. And also, when we do talk about soldiering on, there is something which we call an authority dilemma. That we in authority believe, if we are clinical leaders or clinical directors or medical directors, etc., we need to be very, very conscious that what's happened and what can happen in relation to the authority dilemma, that we are supposed to know the answers. You know what? We don't have all the answers, but we can't say that to everyone because people look up to us and we have to be very conscious, and this can have an impact. Last thing I would like to add is just in relation to being a clinical director as to how we've attempted to manage, because one of the things we've been asked to do is to go through COVID-19 risk assessments for each and every individual. And as most of you will already know, the impact on the BAME community, the Black, Asian and multi-ethnic society, has been huge, not in relation to being infected, but also in relation to being the deaths that have occurred as well in the US and also in the UK. So one of the things that we've done, especially having looked at risk factors. And what we've done is in different ways that different trusts have done that. Some of the trusts have developed algorithms, the scoring systems. For me personally, I've attempted to do that, but then I say, okay, if I've got a score, then what do I do with it? I don't know what to do with it. I can't take them away from the front line. So what we've developed is we've actually developed a very personalized one-to-one supervision sessions. I have almost about 20 odd staff grades and junior doctors and consultants who I line manage. So in the last 3 weeks, we've gone through individual one-to-one, going through their risks, how they can work differently, if they're operating from home, what they can do, what support mechanisms, and it's actually worked very well. I'm in the process of carrying out a survey to get a feedback just to make sure that we're doing in the right way. So that's my tuppence worth. I thought I'd just add what we've done in the NHS and what we can experience. And thank you very much for the opportunity.
Thank you, Dr. Shahid. And let me move on to our final panelist and my very, very dear friend and mentor, Professor Muhammad Waqar Azim, who is the chair of psychiatry at Cedra Medicine and professor of psychiatry at Weill Cornell Medical College, and is co-chair of APPNA MERIT with me. He actually groomed me to work in APPNA MERIT in early days. Professor Waqar, please go ahead.
Thank you, Danish. Thank you for the introduction. It's a pleasure to have you all in this webinar today. You know, I was thinking this is the third webinar we have done in this series. And in all the webinars we have done for COVID, in these 3 webinars, we have about 75 to 85 participants. So it means this area is very important for our colleagues all over the world. Secondly, I think all of you have covered most of the things, but I will like to acknowledge a lot of people. So bear with me for a few minutes. First of all, Dr. Naheed Usmani, you are a brave lady leading the APPNA in such difficult times. We really appreciate your support and leadership, how you leading the APPNA. Both of my friends and colleagues, Danish and Shahid Rafiq, who are the life of APPNA MERIT, which is doing amazing work over the years. Dr. Shehzad Niazi, who I know for a long time at Mayo Clinic, excellent presentation. All my friends panelists, Dr. Aisha Mia from AKU, Dr. Nasar Said from Queen's University, Dr. Ali Hashmi from KEMU, Dr. Sarfaz Said from Indiana University, Dr. Sumera Bukhari from SIMS, and Dr. Shahid Latif from NHS UK. You all presented everything very well. I don't think I have to add anything. But I see a lot of my good friends and colleagues in the audience. I will mention Dr. Nazish Imran at KEMU, Dr. Imran Ijaz Haider at Fatma Memorial, Dr. Ghulam Rasool. We have Professor of Psychiatry and Head of Psychiatry of Bulan Medical College, Quetta, Professor Bilqis from KEMU, Professor Murad Musa from Karachi, and then our friends, a very close friend of mine, Professor Tayyib Tahir from Cardiff, and I see Dr. Amir Birni, President of APNI, also participating. So it's great to see you all participating in such an important webinar. I will just make one comment. I see a lot of residents and trainees who are participating from Pakistan and US. You are very important for us, and you are the future of our generation and future of our country. So keep doing what you all do. Thank you so much. I will give it back to you, Danish.
Thank you, Waqar bhai. That's wonderful. So to start the discussions, I have some very interesting questions, but what I would like to do is to start with some of the leaders that we have in our audience that can give insight into problems and challenges physicians might be facing. So I think I feel the most appropriate person to start this discussion would be to invite Professor Bilqis to give the perspective from a medicine's perspective and physicians' challenges in current environment. Please, Professor Bilqis, go ahead.
Bismillahirrahmanirrahim and Assalamu alaikum. I would first of all appreciate the efforts of Dr. Naheed Niazi and the organizers of this webinar, and it was a very interesting presentation, Professor Niazi, and I really loved that picture of the falling of Icarus, and that really does, give a lot of message, and that is actually happening even before this COVID crisis. I am chairperson of Department of Medicine, and I'm one of the people who is actually dealing with the COVID patients. In Punjab, King Edward Medical University is offering the maximum number of, rather catering the maximum number of patients. We have a capacity of 410 beds. And almost 250 of our patients fall in the moderate to severe degree, severe stage. So we are actually, at a lot of stress level, not only in regards to the management of the patients, But now, since the severity of the patients has, they are more severe, and our doctors are in a lot of stress, we are facing that as well. Initially, we were having more patients who required isolation, but recently you must be knowing that the policy of self-isolation was introduced by the government of Punjab. And following that, all our patients are very, very sick. Professor Ali Madi Hashmi, talked about his services at King Edward Medical University, but I think he underexpressed what the Department of Psychiatry is contributing. Number one, he talked about the psychological first aid, but he did not mention that he has carried out multiple sessions on this. The first session was when we were having less number of serious patients. The first session was for the patients, how to offer psychological first aid to the patients. That was a lot of help for us physicians. The second session, which we recently carried out last week, was for the healthcare workers, because a lot of them, as he mentioned, were falling sick. Out of my own department, I have a strength of 65 doctors in East Medical Ward, and out of them 22 turned out to be positive, and 3 of them went into the moderate stage. So the second series in the session for psychological first aid, which they very kindly offered, was to the healthcare professionals. And then there was third session, which was provided to the district physicians. We started off with the district physicians from Layya and Mandi Bahauddin, which not only touched the clinical aspects of the disease, but also Professor Ali Madi Hashmi and Dr. Nazir Shimran contributed to the psychological first aid as well. So besides that, they are offering 24/7 telemedicine services to patients as well as doctors. And what I really like about it is that they are very, very persistent in their attendance there. We always have a senior consultant there. And I really appreciate the Department of Psychiatry and services of Dr. Ali Madi Hashmi and Dr. Nazish for that. This 24-hour service is, is very, very, is contributing a lot to not only our patients, but also to our doctors and healthcare providers. Besides that, they have always been there to provide psychological support directly. They know about 2 cases. Recently, there was a man who tried to commit suicide in one of the isolation wards of Mayo Hospital, just because his mother had recently died of COVID. He was not able to attend the funeral because of the isolation policy. And he had 3 young girls staying all alone at home. And he tried to commit suicide by hanging himself. And Dr. Nazir Shimran was there for support, and I would really appreciate how she helped us in managing that patient. The second example out of the many is a medical student of our institute who got very, upset. Her father was admitted in the ICU, and she went into a state of panic, and I rang Dr. Ali Madi Hashmi at 6 a.m. in the morning, and he was right there to support us. So as Dr. Niazi said, that with every challenge there is an opportunity, and with every opportunity there are new avenues to improve yourself. Inshallah, I'm also a part of the I'm also a member of the Board of Studies of the Department of Emergency Medicine, which has recently been established at King Edward Medical University. And we are suggesting a psychiatry counter in the Department of Emergency Medicine. So for this COVID crisis in Pakistan, I think it's not only the internal medicine and the pulmonologists and the anesthesiologists and the infectious disease specialists which are offering the services. Psychiatry department is at par regarding their services, and I'm really grateful to the psychiatry department of King Edward Medical University. There's one question I would like to ask from, I don't know, whoever would like to answer. Dr. Niazi talked about patients who are already under stress due to pre-existing psychological disorders, depression, anxiety. There is somebody very close, I know, who is offering services in the COVID department as a physician. And he lost a very dear one in the family, and his own father prior to this COVID crisis. And what he shared with me was that that loss, in fact, helped me during this crisis. I felt that this is a way I can, return back, and what we call sadqa jariya in the, in providing services to the COVID patients. And I found that the fear of COVID was less in him as compared to the rest of us, the rest of the healthcare service. So this was just an observation I wanted to share, that healthcare professional was in a state, is in fact in a state of depression, is on antidepressants, but I think he's contributing far more as compared to the others, just because he says that this does not worry me anymore, because I've had such a big, loss in my life, that it's the other way around. This is just what I, wanted to share with Dr. Niazi, that could this be a coping mechanism in such individuals? If Dr. Niazi could answer that.
Thank you, Professor Wilkes.
Thank you for this.
Thank you for your comment. So I'll give some quick time for Dr. Shehzad to make his comments on this specific question, but I think this is a very important discussion on all the work that is being done in Pakistan and could be done in Pakistan. And I see there was comments earlier by Dr. Tayyib Tahir on application of some of these physician support programs in Pakistan within our resources and our culture in Pakistan. So after your quick comment, Dr. Shehzad, I would love to also take Dr. Tayyib Tahir into this loop and discussion and then expand it to the other panelists. So please go ahead, Dr. Shehzad.
Assalamu alaikum, Dr. Shabir. So you're absolutely right. This is a defense mechanism. If you think about the hierarchy of different types of defense mechanisms that people use, the most mature defense mechanisms that are considered to be perhaps the healthiest among all, one of them is altruism, and the other is use of humor to deal with difficult situations. And when people are able to channel their losses, which enhances their ability to empathize, been there, done that, give you a very different experience about some of these challenges, as opposed to if you have read about it or if you have just trained to do that. So your colleague is wise to use the personal loss to not only help him or herself cope more effectively with the situation, but also in many ways pay it forward and hopefully help a lot of other individuals. And Danish, one quick thing about the support group and panel, there are different types of opportunities that are available to pursue that. And it's different. Some people are much more comfortable in group settings. Some people are much more comfortable in one-on-one situation. One size doesn't fit all. I'm part of some of these efforts, Mayo enterprise-wide, and I'm also working some of these, I'm on the NCC and distress panel, which is for the all comprehensive cancer program for America and for the American Society of Transplant Surgeons and American Transplant Society. They all are struggling with a similar type of challenges as to how to come up with some resources. Dr. Aisha had mentioned about the lack of utility of some of these resources even when they are made available. And we have experienced some of the similar things in some areas because not everyone likes to do certain ways. So that's why we have this whole potpourri of all these things available. And we are noticing that different people use these different approaches in many different ways. So it will be important that when we are thinking about a response, whether that is at the national level, organizational level, department level, that we recognize that we'll have to have multi-pronged approach to do that. And the last thing I will mention is that it is, unlike some of you guys, unfortunately, I'm not as much engaged with a lot of my friends working in psychiatry in Pakistan as much as I would like to. Uh, but hearing about all the wonderful things that you guys are doing in Pakistan, it is very reassuring and it's very heartening. And in a country that has as many challenges, to hear about some of these things, I want to just assure you that these are the things that you guys are doing are genuinely cutting edge type of things that are happening in US as well. So it's just one of those things where everyone is dealing with these things in that way. And obviously you guys are motivated. So I wish you all the very best of luck.
Thank you, Dr. Shehzad. Let me invite Dr. Tayyib Tahir to expand on his comment and question about challenges and limitation in resources in Pakistan. And then I will follow that up by inviting Professor Rizwan Taj to continue his approach at Shifa Hospital. So Dr. Tayyib Tahir, if you can unmute yourself and make your quick comment. Okay, I'm not sure if I can get to Dr. Tayyib at this point. Professor Rizwan, if you are here, do you want to make any comments on this conversation?
I'm very enlightened to hear all these discussions that we have had today. Now, I've been involved at the national level with the Ministry of Health since day one, even when there were no COVID patients and they were planning to bring in the flights, and they wanted us to have a team of psychologists at the airport so that if somebody gets upset about the tests and everything else, they would want somebody to be there. And we had a rota and we had people over there. Then slowly we moved on and things started to happen and we got a lot of patients. And then the ministry started focusing on the frontline healthcare workers. And that was their main thrust. And PIMS was declared as the main Islamabad center for COVID. And currently has about 255 COVID serious patients. And the second site is obviously Shifa, which has about 60 to 70 COVID patients. So the plan was that we would start with the frontline healthcare workers. We would develop a package of training which would include psychological first aid, it would include stress management, and the topic that has been very much asked for by all health professionals is dealing with difficult relatives and patients, how to handle them, how to handle the aggression. That is the topic that is of most interest to everyone. So we developed a package and we started the trainings. In Islamabad, we've had about 7 trainings so far in the past 6 weeks, and from next week we are starting trainings in Shifa Hospital. Then the ministry has asked me to move on and tap the centers out of Islamabad. It's like yesterday I was very much impressed after Imran gave me a detailed analysis of what he has been doing. Today I was in touch with all the 3 sites in Peshawar and then with Ghulam Rasool and Balochistan as well. The problem is the ministry does understand that mental health is a terribly important issue at the moment, and it will be for the next coming months and months and months. The only problem is no one is willing to give us the resources, and there is no budget for them. And that is a big problem. My aim at the moment is to get activated people like Ali Hashmi, who's doing excellent work at Mayo, and get them recognition and encouragement from federal level. And I have taken all the details from him, and I have taken his next schedule as well. And I'm preparing a document, a weekly report, which I present to the ministry every week. And I'm going to document all these activities that are going on and all the problems that the healthcare workers are facing and the psychiatrists are facing. You need to also understand that they're actually scaling down the psychiatric services. They need space for the COVID patients. So the first target is for everyone is the psychiatric services. And we've actually had beds cut down. We've had staff rotated to other places. That is, again, what is happening in the country. The second, when we all talk about stress and the management, we forget about religion. In our culture, religion is so important, so important. We need to understand that, and especially for healthcare workers, we must always keep that in mind, that practicing and promoting and taking hope from religion is a very important part of the whole treatment package. So we also need to understand. Another problem is the female workers, whether be it the doctors or the nurses. They face so much pressure from their families. Please don't go to work, leave your job. There's no need for you to work. We're putting everybody at risk. You're putting your children at risk. You're doing this, you're doing that. And they really have a tough uphill task to try to convince everyone around them that they have to give a duty and then work down. Then the best part is that with myself and then Professor Afridi, we met the Minister of Health. This was about 2 weeks ago. And he said, we'll have a national mental health policy. And he's working on it, and I'm helping him in that. So we hope to have that document, but because I've been around for such a long time and at the federal level, I very well know that these things appear on paper, but when it actually comes to funding and other resources, things are really bad. And then I'll give you another example of recent example. The government has announced a package for the frontline workers that they'll given one extra pay. And they had actually approved it, the Prime Minister had signed it, and everything was going forward. And then when it actually came to the payment, the Accountant General of Pakistan said, we really don't have the money for paying these salaries to the people. And then in the last 3-4 days, there was a lot of noise among the workers that why are we being sidelined in this endeavor, whatever. Anyway, so I think you need to all understand that broadly, we are all similar, but there's minute differences between what's going on here and what can be applied here, and the limitations of resources, which is a big and crucial problem at the moment. Thank you.
Thank you, Professor Usman. Dr. Tayyib Tahir, would you like to make a quick comment over a minute? You're unmuted, but we're not able to hear you, Dr. Tayyib. All right, I'll try to come back to you. I want to acknowledge that we have the president of our sister organization, APPNA, where we are working very closely on many projects and collaborating and looking forward to working together, Dr. Amir Birney. And I would like to hear his point of view, how their organization is working on these challenges and what they might have in pipeline. Dr. Amir, please go ahead.
Thank you, Dr. Bhatti. And it's really been very, very interesting hearing from you and the panelists, their views and the information coming through around mental health and its challenges. And it is, although I do not belong to that specialty, it is something very close to my heart because of the work we do in the communities. I work with medical students, and as Shahid knows, we also work very closely together with our friends and colleagues in APPNA and beyond. And I do feel that this is something which we either are shy to, as in admitting it as a problem within communities, both individually and collectively. And there is certainly a degree of stigmatization associated with it. And how do we tackle it? So I have actually also asked that as a question, that as panelists, how do you think we can actually reduce the level of stigmatization around mental health or the acceptance of it within communities and within professionals, which is surprisingly quite high, that we may have an issue, but we just cannot acknowledge it. Even if we do acknowledge it inwardly, we are out of fear, maybe the repercussions or the damage to our professions, we might not actually seek help. So I've seen that happening. That's one. The other thing is, yes, just like many people across the world have been affected by this very unfortunate circumstances of the COVID crisis, we too have been affected by it in the UK, and quite horribly so. And it's definitely made an impact on our mental health, our stress levels, anxiety, and well-being. As an organization, we have formed a task force, which Shahid is actually part of and leading it in many ways. And this is the mental health task force looking after healthcare professionals working in the NHS and beyond. Because it comes off a conversation once I heard from a little student when we were doing some awareness about studying medicine and what doctors and nurses do. And the comment was that doctors and nurses look after patients. The child turned around and said, who looks after doctors and nurses? And it was such a powerful little statement from a very young mind, and literally stopped people in their tracks saying, yes, actually, you know what, who does look after us? So based on that ethos and philosophy, we are looking at the Mental Health Task Force to develop a series of webinars. Inshallah, one of these will be done on the 8th of July, following on the 15th of July, and we will try and make it internationally available as well. And Shahid could also elaborate a bit more about it, being part of that task force. And it's just looking at our own healthcare force. So thank you for giving me this opportunity. It's been an enthralling absorption of knowledge and information from the panelists and from yourself. So thank you, Danish, and everybody else. Thank you.
Thank you, Dr. Amir Berni, and I want to thank you for all the excellent work your organization is doing, and we're looking forward to more work from you. In the interest of time, given that we are 5 minutes or 7 minutes above our planned closing time, but it's such an interesting discussion, it can go on forever. I am thinking that we should wrap it up here and continue the discussion in future. I see a lot of very, very capable and interesting people joined us and introduced themselves in the chat. I apologize I couldn't get to every one of you, but I'm very appreciative of you joining us and joining the conversation. Let me invite Professor Naheed Usmani, APPNA President 2020, to give her closing comments. Dr. Naheed, please go ahead.
Ji, Assalamu alaikum, Danish. This has been, I think, one of the best APPNA Merit sessions that I've attended. It was so nuanced, so many aspects of the stresses that we as healthcare providers go through. I think there's the stress of the students, the medical students who cannot have clinical exposure and cannot have in-person classes and mentoring and opportunities to examine patients. And of course, the stress of potential COVID infection is there. All of those things, it's affecting each one of us so much. And I particularly liked the Dr. Rizwan Taj's comment as to what the female workforce is going through, the pressure from the family, the guilt that they would be the one responsible for bringing COVID back home to their children and elderly parents. All of this has been huge. I request APPNA Merit team to have Dr. Bakar, Professor Bakar, to have another of these sessions. These are key. I think this is the need of the hour. Thank you, APPNA Merit. APPNA as an organization is so very proud of all the work that is being done. Thank you.
Thank you so much, Dr. Naheed. I think with that, I will close the session for today. And thank you, Dr. Bakar, for putting this together. And thank you for all the panelist speakers for being here. Thank you so much.